Assalamualaikum. I'm Dr. Danish, and I'll be discussing an important topic of calcium, phosphate, and vitamin D. Now, now you are in fourth year, and you must have your experience in different wards. So this basic topic that is calcium and phosphate and vitamin D is it has a special place in your curriculum. It is a revisit topic. That is the importance of this topic is that you can when you go to your ward, when you go to your clinics, you can relate these basic information that how calcium and phosphates are metabolized and what is the role of vitamin D in bone health. So it has a special place in the curriculum that will help you to understand the clinical scenarios when you will be visiting your orthopedic ward and medicine ward. So let's start with today's discussion. The learning objectives of today's discussion, we will be able to describe calcium metabolism. At the end of today's discussion, we'll be able to describe phosphate metabolism, justify their role in maintaining bone structure. That is how calcium and phosphate has an important place in maintaining the bone structure. Then at the end, we'll be discussing the vitamin D, how it is synthesized, how it is being regulated, and how it regulates calcium and phosphate. And then we'll try to just take a small discussion related with the osteomalacia. So today we'll just revisit basic information that how calcium is metabolized, how it is, what is calcium homeostasis, similarly with the phosphate metabolism and its homeostasis, which organs are involved and which hormones are involved in their metabolism and homeostasis. So let's start with today's discussion. Bone, as we know that bone is composed of, if we divide the composition of a bone into two parts, it has an inorganic part and an organic part. The inorganic, which is composed of approximately 67% of the total bone mass, is made up of hydroxyapatite, that is the calcium phosphates. There are various amounts of calcium phosphates. There are some other amorphous calcium phosphates as well, but the major calcium phosphate is in the form of hydroxyapatite, which can be written in the form of Ca10 PO4 OH2. So it's basically the chemical composition of bone. It is a hydroxyapatite. It's a crystalline form of calcium phosphate. So what you need to remember here, that bone is composed of two major parts, the inorganic and the organic. The inorganic, we have calcium phosphates. There are some other amorphous calcium phosphates salts as well, but the major calcium phosphate is in the form of the hydroxyapatite. Then in the organic part, which is approximately makes up around 33% and is called as osteoid. It is made up of type 1 collagen.
Excuse me, sir.
जी.
Excuse me, sir. आपकी जो है स्लाइड कौन सी चल रही है अभी? स्लाइड कौन सी चल रही है? इंट्रोडक्शन वाली चल रही है, फर्स्ट स्लाइड या कौन सी स्लाइड पर है?
फर्स्ट स्लाइड नहीं, ये है बोन लिखा हुआ है.
नो सर, मेरे पास अभी तक आपकी जो फर्स्ट स्लाइड ही आ रही है, कैल्शियम लिखा हुआ आ रहा है. क्लिक कीजिए शेयर स्क्रीन पर, फिर उसके बाद स्लाइड आगे करिए.
एक सेकंड. अच्छा, ये न्यू शेयर आ रहा है यार.
नो सर, शेयर स्क्रीन पर आप जो भी अभी आपकी आ रही है ना शेयर स्क्रीन.
हाँ, एक होल्ड ऑन, देयर इज सम प्रॉब्लम हियर. ओके, इसको दोबारा करते हैं मेरे ख्याल से. एक सेकंड, इसको मैं एग्जिट करता हूँ. Discussing is bones composed of inorganic and organic components. The inorganic part is made up of calcium phosphate salts, and one of the most important calcium phosphate salt is in the form of hydroxyapatite. Then the organic part, which is of lesser proportion, and that is it's made up of 33% of the bone is made up of organic component, which is called as osteoid. It contains type 1 collagen. It contains non-collagen structural proteins like proteoglycans, alloproteins, glutamic acid containing proteins, phosphoproteins, and bone specific proteins, specifically osteocalcin and osteonectin. And then we have growth factors and cytokines as well. Some trace amounts of these growth factors, cytokines are also present in the bone. So these are the major components of a bone tissue. Now, as the composition of bone tissue reflects that most of the bone is made up of calcium and phosphate, so the metabolism of calcium and phosphate plays an important role in the bone health. Now, we are here to discuss that how actually calcium is metabolized, and how body tries to maintain the calcium concentration in a normal reference range. Now, some physiological functions of calcium. It is involved in bone mineralization. It is involved in blood coagulation. It is involved in muscle contraction. It has an effect in enzyme activity. And it's affecting hormone secretion as well. So these are some of the physiological functions of calcium: bone mineralization, blood coagulation, muscular contraction, enzyme activity, and hormone secretion. These are all some of the functions in which the calcium is involved. Distribution of calcium, as we have already talked about, that most of the bone part is made up of calcium and phosphate. So 99% of the total calcium in the body is part of bone. The 1% is in the blood. There are three types of calcium which are present in plasma. We have the ionized calcium, which is basically is a free calcium ion, which is also known as the physiologically active calcium ions as well. So that's make up around 45% of the plasma calcium. Then 40% of the calcium in the plasma is bound to the albumin, which is known as a bounded calcium. And then we have 15% bound to the anions as well. Organic acids, 15% are bounded to the organic acids. So here what we have to keep check on is the free calcium ions, the physiologically active ions, or the active ions. We have to check this plasma calcium level, which plays an important role in bone health. Now, the extracellular fluid calcium concentration is approximately 5 millimoles per liter, and significantly amount of calcium is associated with the mitochondria and the endoplasmic reticulum. The normal level of plasma calcium is 9 to 11 milligrams per dl. So what you need to remember here, that approximately the human body tries to maintain the plasma calcium at 10 milligrams per dl. However, we have a reference range from 9 to 11. That is, if it goes below 9, this means that we are having hypercalcemia, and if someone is having the plasma calcium concentration greater than 11, he's having hypercalcemia. Both are related with clinical manifestations. So that's an important reference range which you need to remember. That is, the normal level of plasma calcium is 9 to 11 milligrams per dl. As you may see patients who are suffering from different disorders, maybe low vitamin D levels or low plasma calcium levels, you need to check their plasma calcium levels, and they should fall in a reference range from 9 to 11 milligrams per dl. Now, calcium balance. Calcium balance is essential. We cannot synthesize it, as the body cannot synthesize calcium. So, nutritionally, calcium is essential in our diet. We need to take in our diet. So, intake should be equal to the output of calcium, and that is where we can get a balance of calcium. That the intake of calcium should be equal to the output of calcium. So on the basis of this, we can have two conditions. We can have negative calcium balance, in which the output is greater than intake. For example, we can have negative calcium balance that can lead to osteoporosis. So if someone is losing calcium in through urine, and it's not taking the calcium in the same amount or greater amount, he may suffer from osteoporosis. Now the reasons are various reasons. We're not going into detail at this point, but what you remember here, that calcium balance can be negative, it can be positive. The negative calcium balance, when an individual calcium output is greater than the intake of calcium, whereas the positive calcium balance, in which the intake is greater than the output, and this may occur during growth. When uh, the children are growing, their intake is greater than their output, so more and more calcium is being deposited in the bones as their storage site, and in the formation of mineralized bone as well. So calcium balance can be negative or it can be positive. Now, calcium homeostasis, as uh, we are discussing how the calcium is being maintained in its normal reference range, we should understand this, that there can be two possible conditions. Either it can be low calcium concentration, or it can be high calcium concentration. So the nature has given us different mechanisms that maintains the plasma calcium concentration in its normal reference range. Now, what you need to remember here, that calcium homeostasis is maintained by a number of organs, in which number of organs like skeletal system is involved, the GIT is involved, then GIT is involved, the kidneys are involved, the intestine is involved. So all these organs are involved in calcium homeostasis. So if you just recount the organs we have which are involved in calcium homeostasis is the skeletal system. Can you recall? Can you write in the text box, text chat box? Okay. Yes, the kidneys are involved, the bones, the skeletal system, the intestine is involved for calcium absorption. Yes, excellent. Sumaya Jafri, Maruf Moin, thank you. Skeletal GI, kidneys, intestine. Okay. So Amna Shah. Okay. So yes, Sidra Musa. Yes. Okay. So we have organs which are involved. The major organs involved in calcium homeostasis is, as we have discussed, we have skeletal system, we have intestines, we have kidneys, we have bones. Okay. Now, not only this, in calcium homeostasis, we have organs involved, but we have some hormones involvement as well. The hormones also plays an important role. For example, as you just rightly uh, you just wrote it in your text box, can you please write it again? That the possible hormones which are involved in thyroid. Yes, Osama Said. Yes, thyroid. In which form? Calcitonin. Yeah, Sidra Musa. Excellent. Parathyroid hormones and calcitonin. Okay, excellent. Okay. Thyroid, calcitonin, parathyroid. Okay, excellent. So we have hormones. The third hormone which can be considered as a hormone. Okay, Priyanka. Yes, vitamin D can be considered as a hormone, because it has a vitamin D receptor that can act on the nucleus and can act as a hormone, similarly act like a hormone. Yes, so we have three major hormones. We have parathyroid hormone, we have calcitonin, then we have some effect of vitamin D. Growth hormone, yes, to an extent, but calcium metabolism, yes, not directly. Okay, so these are some of the hormones which are being involved. Now, so calcium homeostasis, if we see from this perspective that it should be maintained in a normal reference range, that is approximately around 10 milligrams per dl. So we can have two conditions. It can be increased calcium levels, that it can go up, for example, hypercalcemia. And when a person is having hypercalcemia, the thyroid gland releases calcitonin, and calcitonin decreases the activity of the osteoclast cells, that decreases the calcium reabsorption, also causes the calcium reabsorption in the kidneys decreases. So the calcitonin decreases the osteoclast activity and decreases the calcium reabsorption in the kidneys. That can lead to decrease in the calcium levels in the blood, and the calcium level comes to normal. Whereas if on the other side, if the calcium levels goes below, if it goes below, or it can be hypercalcemia, the parathyroid glands releases the parathyroid hormone. So there are specific receptors that can sense that the body is having low levels of calciums. So parathyroid glands will kickstart releasing the parathyroid hormone. This parathyroid hormone will act on the osteoclast cells that causes the resorption of the bone mass and releases the calcium. Calcium is reabsorbed from urine by the kidneys and causes the calcium absorption in the small intestine, increases by vitamin D synthesis as well. So parathyroid hormone not only causes the release of calcium from the bones, it causes the reabsorption from the kidneys, but it also increases the activity of vitamin D by converting it into its active form, that is 125 dihydroxy calcitriol is being formed that acts on the intestine and increases the vitamin and increases the calcium absorption. In this way, the calcium level the normal calcium level is reached, and it and a normal reference range is maintained. So we can have two conditions, hypercalcemia or hypercalcemia, but the body tries to maintain the calcium around approximately 10 milligrams per dl. Now, so not only this, we have the intact organs that is regulating the plasma calcium level. We have hormones, and then we have vitamins with vitamin D that plays an important role in calcium homeostasis. But the dietary intake of calcium also plays an important role. So the recommended dietary allowance, that is milligram per day, is now, can you guess, or if you know, please write in your chat box, or if you can name the food items that are rich in calcium, please write in the chat box. Milk, okay. 1000 milligrams per day. Faham Fatma, okay, excellent. Cheese, milk, cream cheese, milk, almond. Okay, orange juice. Okay, Zara, think again. Orange juice contains calcium. Maruf, liver fatty fish contains calcium. Okay, we're talking about calcium. Okay, any guess that how much calcium is present in a cup of milk? Any idea? Any idea how much calcium is present in a cup of milk? Sayyida Sarah, 450, 250, okay, not bad. 150, not bad, okay. I'm not sure. Okay, it actually depends on the source of milk, whether it's a cow or buffalo, it may vary. Okay, so we just take it. Lippincott mentions orange juice. Okay, Lippincott mentions orange juice, it contains calcium. Okay. Yes, but rich sources, 1/3 to 1/4 of recommended dietary allowance. Yes, Nurul Ilma. Yes, excellent. Okay. Arjun Nadeem. Okay, yes. So basically, what I want to emphasize on this, that a cup of milk contains only 300 milligrams, approximately 300 milligrams in each cup of milk. So if someone is having low calcium or osteoporosis or bad bone health, you cannot recommend to, if already developed, if already developed hypercalcemia, low vitamin D levels, and low bone mass density, you cannot recommend her to drink a liter of milk. Okay, so that's not possible. Okay, so in a cup of milk, there's only 300 milligrams, which is present, and you cannot just tell her simply that go home and uh, uh, just start drinking milk. So it's not possible that you can reach up to 1000 milligrams per day. So the only way uh, you can reach up to this level is the supplementation, that is the calcium supplementation. Okay. Okay, so that's year-wise dietary allowance. For example, if your age, I guess your age lies between from 19 to 30 years old, as you are in fourth year. So your recommended dietary allowance is 1000 milligrams per day, and it goes to 1200 when someone reaches around 50 years of age, and then it goes above, it goes on and on. Now, if a female, there is an extra amount is being added if someone is a female and more than 50 years of age, her recommended dietary allowance is 1200 milligrams per day. So most of the females who are suffering from osteoporosis and osteomalacia, their the requirement of calcium cannot be fulfilled by just drinking milk and taking food items that are rich in calcium. So you need to give the calcium supplementation. So these are some of the calcium supplementation which are available uh, over the counter without any prescription. So these are some of the calcium supplementation. These are some of the examples. Now, so coming back to the hormonal regulation, how the calcium is being is being maintained, how the calcium level is being maintained. So we have the hormonal regulation. We have discussed that there is a parathyroid gland that that secretes a parathyroid hormone, which acts on both bone and kidneys. If the parathyroid gland senses hypercalcemia, it will activate the release of parathyroid hormone. The parathyroid hormone will stimulate the osteoclastic activity, releases the calcium and phosphate from the bones. Whereas it acts on the kidneys and causes the absorption of calcium, increases the absorption and excretion of phosphate, and at the same time it activates the 1-alpha hydroxylase enzyme that activates the vitamin D. It activates the vitamin D by circulating 25 hydroxy vitamin D into 125 dihydroxy vitamin D, that is uh, dihydroxycalcitriol. And then this is the only active form of vitamin D, that is calcitriol, which acts on the intestine and kidneys. In the intestine, vitamin D promotes intestinal absorption of calcium and phosphates, whereas on kidney tubules, it promotes the renal reabsorption of calcium and phosphate. So in this way, the calcium is being regulated. The normal levels of calcium is being regulated by parathyroid glands, the calcitonin, and the vitamin D. Now, the reasons, the major reasons of hypercalcemia, we can have the patient can have primary hypothyroidism, hypomagnesemia. Hypermagnesemia is also accompanied with hypercalcemia. Then hypoalbuminemia can also affect the levels of calcium because some of the portion of plasma calcium is binded with the albumin. Then acute pancreatitis, vitamin D deficiency, renal diseases, chronic renal diseases, polycystic kidney disease, renal disease can also affect the calcium levels. Then rhabdomyolysis and pseudohypoparathyroidism, all are the causes of hypocalcemia. Some of the reasons of hypercalcemia, we can have primary hyperparathyroidism, we can have hyperthyroidism, benign familial hypercalciuria, malignancy, multiple myelomas, increased vitamin D, thiazide diuretics, and prolonged immobilization all leads to hypercalcemia. So these are some of the reasons of hypercalcemia. Now, coming to the phosphates. Now, the relation between calcium and phosphate is really important for the bone health. The some physiological functions of phosphate is 80% of total body phosphate is contained in bone. The phosphate is involved in ATP, which is the energy currency of a cell, and the high energy phosphate bond uh, gives the characteristic of chemical energy to the adenosine triphosphate. Then it is an essential element in phospholipid cell membranes, in nucleic acids, phosphoproteins, and is also critical for activity of several important enzymes as well. These are some of the physiological functions of phosphate. Its distribution, total phosphate is approximately from 500 to 800 milligrams, whereas most of the phosphate is present in bones and teeth. 80 to 85% of phosphate of the body phosphate is present in bones and teeth. The normal plasma level is approximately from 2.5 to 4.5 milligrams per dl. The organic phosphates that ranges from zero point 0.5 to 1 milligrams per dl, whereas inorganic it can be 3 to 4 milligrams per dl in adults, whereas from 5 to 6 milligrams per dl in children that are inorganic phosphates. Now, as you can see, most of the phosphates are in bones and teeth, and they are is basically these are the skeletal system and the teeth, which represents the storage site of phosphate. Now, the food items which are rich in phosphate or phosphorus, they are meat, poultry, egg, and fish. Fast foods, because they use some salts which are rich in phosphate. Then cheese itself is rich in phosphate. Colas, phosphoric acids, colas, all the soft drinks are rich in phosphorus. Then fish, flax seeds are rich in phosphorus, and milk itself is rich in phosphorus. Okay, now the daily intake. Daily intake. The recommended daily intake for adults is 700 milligrams, whereas for children is approximately 1250 milligrams. Regulation, how it is being regulated, same as that of calcium. The parathyroid hormone lowers blood phosphate concentrations by increasing the renal excretion. Vitamin D acts to increase phosphate in the blood due to increased phosphate absorption in the intestine, increased phosphate reabsorption in the kidneys. So the major regulation is done by the parathyroid hormone that tries to lower the blood phosphate concentration by increasing the renal excretion. More and more phosphate comes in the urine, whereas the vitamin D, it acts to increase phosphate in the blood due to increased phosphate absorption in the kidney, intestine, as well as in the reabsorption in the kidneys as well. Now, it can be two severities. It can be hypophosphatemia or hyperphosphatemia, that is low phosphate plasma concentration and increased phosphate plasma concentrations. Hypophosphatemia are very common in hospitalized patients because of infusion of dextrose solution can lead to hypophosphatemia. Use of antacids that bind to phosphates can lead to hypophosphatemia, and alcohol withdrawal also leads to hypophosphatemia. Whereas on the other hand, hyperphosphatemia, it can be due to renal failure because of unable to excrete out phosphates in the urine. Neonates are more susceptible to hyperphosphatemia, and increased breakdown of cells, for example, in severe infections and neoplastic disorders, also leads to hyperphosphatemia. So we can have two severities: hypophosphatemia and hyperphosphatemia. So we are done with calcium and phosphate and how they are being how the levels are being maintained. Now, if someone wants to summarize that how calcium and phosphate concentrations are maintained. Any idea? If someone want to answer this, summarize. Sumaya Jafri, excellent. Parathyroid hormone. Okay. Hormonal regulation, calcitonin, vitamin D, parathyroid hormone. Vitamin D, yes. calcitonin, Mama Saeed, Maruf Moin. Yes, excellent. Okay. Acts on the intestine, Maruf Moin acts on the intestine and kidneys and bones. Okay. Okay. Now, coming to the vitamin D, that is a sunshine vitamin. It is a fat soluble vitamin. It is one of the fat soluble vitamins. It resembles sterols in the structure. It contains a sterol structure which is very much similar to the cholesterol and other steroid hormones. It functions like a hormone because it has its own vitamin D receptor. Vitamin D3 synthesis occurs in the skin and proportional to the exposure to the sunlight. Dark skin pigmentation due to melanin cause adversely influences the synthesis of the cholecalciferol. Now, these are some of the important points here with vitamin D. What you need to remember that vitamin D is one of the fat soluble vitamins. And the structure resembles the sterol. It has a sterol structure, which is same as that of cholesterol, steroid hormones, and so on. It acts like a hormone because of its structure, and it can bind with the vitamin D receptor. So it has its own receptor. So vitamin D3 synthesis occurs in the skin. It's proportional to the exposure to the sunlight, and dark pigmentation decreases the uh, vitamin D synthesis. Now the chemical structure cholecalciferol. In the blue box, as you can see, we have 7-dehydrocholesterol, which is the precursor for vitamin D3, which is cholecalciferol. So 7-dehydrocholesterol is a precursor. The UV radiation falls on our skin, and 7-dehydrocholesterol is converted into vitamin D3, which is cholecalciferol. Whereas ergosterol and ergocalciferol, they are present in the plant sources. So if you talk about from the view of dietary intake of vitamin D, the ergocalciferol are present in plant sources, whereas vitamin D3 or cholecalciferol are present in the animal sources. However, after digestion and absorption, all the types of vitamins are converted into cholecalciferol in the hepatic tissue. Now, some of the dietary sources: the plant source ergocalciferol D2, animal source vitamin D3, that is cholecalciferol. The endogenous vitamin precursor is 7-dehydrocholesterol, which is converted into cholecalciferol in dermis and epidermis exposed to the sunlight. That is because of the UV light. The rich sources, dietary resources, we have fatty fish, liver, and egg yolk. Um, as many suggest or may think that milk, if a milk is a good source of calcium, it may be a good source of vitamin D, but unfortunately, it is a very poor source of vitamin D. Milk is a very poor source of vitamin D. So advise intake approximately from 5 micrograms to 200 international to age 50, and from 400 to 600 international units after age 50 years of age. These are some of the diets which are rich in vitamin D, which we have fish. For example, we have salmon fish, which is rich in vitamin D. Some fortified foods are there. Then mushrooms, which are rich in vitamin D. Cheese is rich in vitamin D, and eggs are rich in vitamin D. Now, normal serum values of vitamin D is the circulating vitamin D is 25 hydroxy uh, cholecalciferol. If the normal adequate levels ranges from 50 to 70 nanograms per ml. So what you should remember, the normal reference range is from 50 to 70 nanograms per ml. 30 to 50 is minor deficiency, and less than 30 is severe deficiency. Whereas excess or toxicity because of continuous intake of vitamin D can lead to toxicity of vitamin D if it's then the range is more than 80 nanograms per ml. So we can have conditions like severe deficiency, minor deficiency, and those plasma levels which falls in the normal range. And then we have toxicity levels which are greater than 80 nanograms per ml. Metabolism, D2 and D3 are not biologically active. The only biologically active form of vitamin D is 125 dihydroxy cholecalciferol. The metabolize identically in the body and converted to the active form of vitamin D. So all the types of vitamin D are converted into its active form of vitamin D. Now, this is some of the diagrammatic representation how actually vitamin D is synthesized in our body. Some precursors like 7-dehydrocholesterol is converted into cholecalciferol, that is vitamin D3, by the ultraviolet light, which falls on our skin, converts the precursor into cholecalciferol, which is vitamin D3. Some of the vitamin D are also coming from the diet as well. So vitamin D3, some foods which are rich in vitamin D are oily fish, meat, eggs, fortified foods, and they are directly digested and absorbed and then converted into vitamin D3 by 25 hydroxylase enzyme. And then it is converted into calcidiol, which is 25 hydroxy vitamin D. And then the enzyme which is being activated by parathyroid hormone is 1-alpha hydroxylase enzyme that converts the 25 hydroxy vitamin D into 125 dihydroxy vitamin D. So, and this is the only calcitriol is the only active form of vitamin D in the body that maintains the calcium and phosphate in the normal reference range. Now, how the active of vitamin D is being regulated, as the previous information may overlap, as we have discussed in calcium homeostasis and phosphate homeostasis. The information may overlap here, as all of is basically the nature has created the interlinked mechanisms. So the uh, the activated the cholecalciferol is being formed uh, through UV light, and then cholecalciferol is converted into 25 hydroxy cholecalciferol by the 25 hydroxylase enzyme in the liver, and then this goes into the kidneys, where the enzyme is an important enzyme is 1-alpha hydroxylase enzyme, which is activated by the parathyroid hormone and low phosphate concentrations that converts the 25 hydroxy cholecalciferol into its most active form, which is 125 dihydroxy cholecalciferol, which is calcitriol, and that causes the calcium and phosphate, that increases the calcium and phosphate absorption. So this is how it is being regulated. The active form vitamin D is regulated by the plasma calcium levels. On top of it, it has a hierarchical system. The decreased plasma calcium concentration activates the parathyroid hormone. The parathyroid hormone activates the uh, alpha 1 hydroxylase enzyme. As at the same time, low phosphate concentrations also activates the alpha 1 hydroxylase enzyme. And then the 25 hydroxy cholecalciferol is activated to form the calcitriol, which acts on the renal tubules and the intestine. So as well as on the bone tissue as well. So the calcitriol, which is the activated form, acts the on the receptor which are present on the intestine, causes the bind with the receptor, forms the calcitriol receptor complex. The messenger RNA is activated. It forms due to transcription and translation process, forms calcium binding proteins. More and more calcium binding proteins are formed so that the calcium can be absorbed from the intestine. And so there's an intestinal brush border. Uh, in the diet, the calcium is being taken, and then more and more calcium binding protein is being formed so that more and more calcium is being absorbed, and then it goes into the bone for bone formation and turnover. So in this way, the vitamin D, the activated vitamin D, that is calcitriol, is being regulated by plasma concentration, by parathyroid hormone, and by phosphate level. So there are three factors that that helps in the regulation of calcitriol. The first is the plasma concentration of calcium, the plasma concentration of phosphate, and the parathyroid hormone as well. So all these increases the plasma concentration and maintains the plasma concentration in a normal reference range. Again, this is taken from your book Lippincott. Decreased plasma concentration of calcium increases the parathyroid hormone. Parathyroid hormone activates vitamin D, more and more formation of calcitriol, acts on the calcium mobilization from bone, increased renal reabsorption, decreased renal excretion of calcium, increased calcium absorption from the intestine, and ultimately increases the plasma calcium concentration. Now, some of the biochemical functions of vitamin D. Calcitriol is a biologically active form of vitamin D. It regulates the plasma level of calcium and phosphate, as we have already discussed. Not here, but also we have discussed in calcium and phosphate how the calcitriol plays an important role. So um, just to reinforce this idea that vitamin D plays an important role in calcium and phosphate metabolism. And this vitamin D act at different levels. It can act at the level of the intestine, kidneys, and bones as well to maintain the normal plasma calcium concentration. In the intestine, it increases the calcium and phosphate absorption of intestine by causing the increased expression of genes for calcium binding proteins as well as calcium ATPase in the intestinal cell. So as I've told you that vitamin D is not only a vitamin, but it can act as a hormone. It can bind with the vitamin D receptor causes the expression of the genes for calcium binding protein. More and more calcium binding proteins are formed and causes the increased absorption of calcium in the intestine. It increases the calcium absorption by actively transporting calcium across the plasma membrane against the electrochemical gradient. So basically, uh, it's an active mechanism. In the bones, increased synthesis of calcium binding proteins at the same time. It causes osteocalcium. More and more proteins like osteocalcium alkaline phosphatase are more proteins are synthesized. Increased calcium and phosphate ions in the bone. Ions enhance the mineral deposition in the bone. Vitamin D, along with parathyroid hormone, promotes bone resorption and calcium mobilization to raise the levels of calcium and phosphate in the blood as well. So these are some of the effects of vitamin D on the bone tissue. That it increases the synthesis of calcium binding protein, it increases the calcium phosphate ions in the bone, and along with parathyroid hormone, it promotes bone resorption so that the calcium is mobilized to maintain the calcium and phosphate levels in the blood. Whereas, as we talk about kidneys, the vitamin D acts on the kidneys. It minimizes the excretion of calcium and phosphate through kidneys. It increases the reabsorption of calcium and phosphate in the renal tubules. Decreased excretion enhance absorption, ultimately leading to the increase in the plasma calcium. Now, vitamin D deficiency. Deficiency can lead to poor bone and oral health, deformity and weakness of the bones. Causes can be insufficient exposure to sunlight. As It's really important to discuss here that uh, most of the public living in Karachi, they are having vitamin D deficiency because most of us avoid having sunlight, and we do not take food items that are rich in vitamin D. So most of us are actually suffering from vitamin D deficiency. They are not in a normal reference range. They are mostly below 30 nanograms. So it's really important to check vitamin D levels here, especially in Karachi. So consumption of diet lacking vitamin D can also one of the reasons of vitamin D deficiency. Strict vegetarians can also have vitamin D deficiency. Chronic alcoholics can have vitamin D deficiency. Liver and kidney diseases, as both the enzymes that helps in the conversion of active of vitamin D, they cannot act properly. So both liver and kidney diseases can lead to vitamin D deficiency. Fat malabsorption syndrome, as vitamin D is a fat soluble vitamin. So uh, fat malabsorption syndrome can also lead to vitamin D deficiency. Northern latitudes, reduced exposure to ultraviolet light also leads to vitamin D deficiency. Covering the entire body for religious customs accompanied with poor diet. However, you may disagree, but it's written in one of the books, so I thought it's important to mention here. But obviously, you can disagree. So, strict vegetarians, chronic alcoholic, liver and kidney diseases, fat malabsorption, northern latitudes, reduced exposure to ultraviolet lights, covering the entire body for religious customs accompanied with poor diet can lead to vitamin D deficiency. Now, the manifestation of vitamin D deficiency, it's a little bit different in children and adults. In children, it is manifested in the form of rickets. Rickets is basically characterized by continued formation of the collagen matrix of bone, but incomplete mineralization, resulting in soft, pliable bones, and that can lead to bowing of bones, the bowed legs, knock knees, outward bowed chest, and knobs on ribs are some of the characteristic findings in children who are suffering from the rickets of vitamin D deficiency. Whereas in adults, it is manifested, vitamin D deficiency is manifested in the form of osteomalacia, which is due to demineralization of pre-existing bones, increase their susceptibility to fracture, softening of bones, bending of spine, fractures and bowing of legs are some of the characteristics of osteomalacia. So vitamin D deficiency, we have discussed that some of the factors that can lead to vitamin D deficiency and how vitamin D deficiency can be manifested differently in children and in adults. Rickets in children, osteomalacia in adults. This is a diagrammatic representation of rickets. As you can see, the bowing of legs, big joints are involved, curved bones, bony, bony ribs are some of the signs and symptoms of vitamin D deficiency. Okay, so we have come to the end of our discussion. Uh, the chat box is open. The reference books for uh, this important discussion, it is calcium and phosphate metabolism, homeostasis, and vitamin D. The recommended textbooks are Lippincott, uh, the Chatterjee, and Harper. So if you have any queries, I'm here to answer your queries. If you have any queries, please. Any queries if you want to ask. Okay. Anyone here who wants to answer this? The correct option? In hypoparathyroidism, plasma calcium, which is the correct option. C. Okay. Mahanur, Amjad, Maham Fatma, Dania Tariq, Hussein, Ahmed. Why is it C? Can anyone explain why it's C? Why the correct option is C? Its plasma calcium is low and organic phosphorus high. Can anyone explain? Okay, here you go. Muhammad. Okay, Pether causes release of calcium, blood removal phosphate by kidneys. So, okay, Pether normally increase calcium and decreases phosphate. Okay, Ruben refers to more. Okay, Priyanka, accident, neurolima. Sidram Musa, Amna Shah, low calcium use option because the key phosphate is increased calcium absorption. Okay. Now the true option for this tubular reabsorption of calcium is increased by CBC. Okay. C. Okay. BOS 25 hydroxy. Okay. Why B and why C? Any idea? Abdul Razak. Okay. Excellent. Amna Shah. Excellent. C is 125 dihydroxy, which is okay. Excellent. Nurul Ilma. Afrin Arif is the active form. Okay. Excellent. Okay. Answer this one. Calcitriol facilitates calcium absorption by increasing the synthesis of the following in intestinal mucosa. Which is the correct option? Calcitriol, Sidra Musa A. Okay, it's A. Okay, excellent. Okay, so we are done for today, and I hope you have gained some information, and you can use this information when you will be studying pathology and all the diseases related with the bone health, like rickets, osteomalacia, and osteoporosis. So thank you for listening, and I hope I have. Okay, ji. Okay, so I'm leaving for this discussion. Thank you for
यस
listening.
सर, अस्सलाम वालेकुम
जी
सर,
हाँ
एंड कर दूं लेक्चर?
हाँ कर दें.
ओके
Okay.
सर.